News and information from Georgia State experts about the current global health crisis. This is 88 Affairs, a program for our Georgia State University community and WRAS listeners. I'm your host, Andreas Preuss. Joining me for a conversation about Georgia State COVID testing, a probable vaccine, and what to expect next semester during this pandemic is Rodney Lyn. He's the Interim Dean of the Georgia State School of Public Health and a member of the GSU COVID-19 Task Force. Dean Lyn's research is focused on childhood obesity prevention, school and community health, and the reduction of health disparities. Dean Rodney Lyn, thanks for joining me.
Well, thanks for having me. I'm looking forward to the conversation.
Well, I want to start our conversation with the rather sobering comment that was issued by the CDC Director, Robert Redfield. He said, "The reality is December and January and February are going to be the rough times. I actually believe they're going to be the most difficult time in the public health history of this nation." And he was basically citing the stress on the health system. What are your thoughts on that comment?
Well, I think he is being very realistic about the path ahead and what lies ahead. If you look at the data, it indicates that we are at record levels in terms of deaths, in terms of hospitalizations, and that really doesn't bode well for the outcomes and health outcomes. And that's really what he's speaking about, that the number of cases, hospitalizations, and deaths are likely to exceed the pace that we've seen to this point in the pandemic. So that's very sobering and should be a wake-up call or a reminder for all of us to take precautions and to implement all measures that we can in our daily lives to reduce the spread and risk of transmission of this virus. And that obviously means social distancing, wearing a mask, and avoiding unnecessary trips to places where you're going to be exposed to other people and potentially spreading or contracting the virus.
And that's a great thing to ask of people, and many people do that. What's particularly stressful is it's the holiday season. We just got finished with Thanksgiving, Christmas is on the horizon, New Year's Eve. It's a difficult thing to tell people not to socialize with family and friends during the holiday season. Is this just a public health necessity that people do take precautions even though they're inclined not to because of just the holidays?
Listen, there's no question that we're in public health, we're asking people to do something that is less than comfortable, to make a choice that is different than they might otherwise make, and that is to not gather large groups of family and friends during the time of the year that is a tradition for many individuals and communities. But we also have to look at the realities that we're facing, and if we all make some sacrifices in the short term, we will all benefit in the long term. The ability for our economy to be, our cities to be open, it really relies on us having a healthcare system that's not overburdened. It really relies on us having people that are well and able to contribute. And if we don't change our behaviors and take the precautions that we need to, then we really run the risk of not just mass cases and hospitalizations and death, but also really traumatic negative impacts on our economy. And that also leads to additional pressures, burden, and negative ramifications for individuals and families. So, it may seem like, hey, I don't want to give up gathering with my family, but we really want people to avoid large gatherings, to take the precautions that have been advised. And if they do gather, to take steps to really reduce the risk of transmitting the virus, and that is wearing a mask, maintaining distance even if you're visiting with friends and family, and where possible getting testing that would really help to illuminate people that might have an infection but not be aware of it because they're asymptomatic.
Well, you bring up a good point, which is the tension between public health and economy. And we saw a lot of this play out in the early months of the pandemic where Brian Kemp reopened the state of Georgia pretty quickly. And then you had seen a surge in the summer, whether that was predicted or not. The winter surge was always kind of predicted. So what the CDC director was saying that, this is going to be the most difficult time in public health history of this nation is something that, people would be expecting. Do you think that mask wearing that had become political, do you think people are getting the message that is probably the best way to protect themselves and other people?
I certainly hope so. When we really look at the spread of the virus across the country, it really does suggest there's more that we can do. There's more that individuals can do. There's more that leaders of cities, counties, and states can do to really reduce the risk of virus transmission. There certainly has been a lot of politics involved, unfortunately, in the wearing of masks and whether or not there should be mask mandates and should we shut down the economy, not shut down the economy. And I think that's unfortunate. And the way that I view it, these strategies need to be used in when we're talking about prevention, when we're talking about wearing masks, that needs to be universal. And I would encourage, leaders in our cities, counties, states, where possible, to mandate the wearing of masks. That should be a requirement in public spaces. By doing that, we actually increase the probability that we can keep businesses open, keep our economy moving strong, and allow people to remain employed. So it's really interesting that sometimes those that are most against the mask wearing and the mandating of masks are, very concerned about the economy. And the reality is that being more supportive of wearing masks is likely to help the economy to remain robust and open and strong. So I think, it's unfortunate politics has, become such a part of this, what doesn't need to be a debate, but this debate. And I think there's lots of space for people to support both, and that's what I think we should be doing.
You also saw education become political with the decision to keep students in class or attend online school. Was that something that you were predicting or seeing that would develop as the fall semester came around? And that's not just for college campuses, but also K through 12. There seemed to be a lot of back and forth on whether to send kids to class or keep them remote learning. Was that a surprise?
No, I'm not surprised that there was a lot of debate around that topic. I think if we look at what we knew at the time, I think there was and continues to be emerging evidence about COVID-19 and the extent to which kids are susceptible. And, when decisions needed to be made about classes this fall, I don't think that the data was as clear as it is now. And that's not to say we know all that we need to know, but there was lots of reason to be concerned. As a society, I think many would agree that among our top priorities is to protect our children. And so those that showed a lot of caution did so for good reason. At the same time, you had those that thought that ensuring that kids were in school was equally important and that their risk may have been less than what it is for us. And so I see that point of view as well, that having kids out of school, in-person school for long periods of time, certainly creates risk to their health and development. And we want to ensure that trajectory remains on the right course. And so, I fully understand the concern on both sides.
I'm speaking with Rodney Lyn. He's the interim dean of the Georgia State School of Public Health and a member of the university's COVID-19 task force. Dean Lyn, tell me about the testing on campus, the COVID-19 testing. It kind of rolled out, it was something that it seemed to be not many people were taking advantage of it. I think you did offer free testing for students, faculty, and staff. What are your thoughts on the whole testing policy and process on campus?
Well, first, we've been, as a university, doing testing since students came back to campus this fall. It was initially focused on the students that are living on campus in the residence halls. And so there's been a testing program available to those students from the time they returned to campus. That testing program has been expanded now to be available to any faculty, staff, or student who is, part of the Georgia State community, regardless of which campus they call their home campus. So that testing is provided via a saliva test, and results are, provided directly to the individual, usually within 1 to 3 business days. We've had an increase in testing, obviously, since we were able to expand testing campus-wide. And the good news is we continue to have a low positivity rate on campus. And so we feel good that we've been able to maintain that low positivity rate. But we're obviously continuing to test as much as we can and monitor what's happening on campus. I'd also note that no evidence of transmission of the virus in classrooms or anywhere else on campus, with the exception of a few cases in housing, which we, are able to recognize quickly. And our medical director is the lead for the university in following up on those cases and tracing contacts and so forth.
And a great resource is the ahead.gsu.edu/COVID-19 resources, where you can actually see the weekly summaries of the number of tests, the number of positive results, and the percent positive. And you can see a steady increase really from August 15 through 21, where 67 people were tested, to November 21 through 27, where more than 1,000 tests were submitted, with a number of positive results being 28. So is it difficult when you don't have that many students on campus? And we did have an incoming student body of 52,000. It was one of the biggest, it was the biggest in the history of Georgia State, where many of those students are not on campus. They never have set foot on campus, but they are then getting tested on their own, whether it's through, something in a drive-through or a pharmacy or something like that. Are you collecting those results as well and putting them into your weekly summary, or are these only tests that Georgia State has initiated?
Well, the weekly summary on the GSU Ahead site, there's a weekly summary that reflects tests that are being conducted on the Georgia State campus, again, under the direction of our medical director, Dr. E.J. Asanovi. And then there's also the opportunity on the GSU Ahead site for faculty, staff, and students to report voluntarily test results from other tests that they may be doing on their own through drive-through or through their primary care physician or in other locations that are not run or administered by Georgia State. So you'll see on the GSU Ahead site, there's also a place for voluntary self-reporting positive test results, and that's broken down by faculty, staff, and students. So we are tracking both of those, and there are also positive cases that are on campus, and we do remove from the voluntary reporting positive cases on campus, where those individuals go into the voluntary reporting system and report there as well. So that prevents double reporting, if you will.
Yeah, you're absolutely right. The voluntary self-reporting of positive test results are on the website, and the numbers are just shockingly low, at least to me. Is this something that you're like, yeah, this is just kind of the way these things happen? Because, you have the tests you administer. You've got, like I said, 1,100 tests were administered in the month of November, the 21st to the 27th. But then the same week, voluntary, 0, 2 staff, and 2 students.
Yeah, certainly the large number of tests that we did suggest that people really took advantage of the testing that we were providing. Certainly the voluntary reporting is just that, voluntary. We can't compel people to report their information. So it's likely that there are more tests that, are being done and not reported, but there's no way for us to really know that or track that. And we continue to invite members of the community to report that information to us.
Fair enough. And you were offering saliva testing at Georgia State, the free saliva-based testing for students, faculty, and staff. And you said a lot of people took advantage of that.
They did. I mean, you can look at the numbers and how we've increased testing over the weeks, and the week, leading up to Thanksgiving being by far the week where we've done the most tests that we've ever done. So we hope, as we're in the holiday season, that campus community will continue to take advantage of the testing that's available. It's a way to not just keep campus safe, but to keep families safe as well as students as we go and visit, those that will return home from campus, but also as we interact with our communities, a way to ensure that we are not unknowingly infected.
The saliva test seems to be a rarity, and I've taken several COVID-19 tests, all negative, and the majority have been the nasal swab. Why is Georgia State going with the saliva-based testing?
Well, we were initially using the nasal swab, and there are a couple of different types of tests, and one is what we call this PCR test, and this is really a diagnostic test that uses technology called PCR, short for polymerase chain reaction, and it really amplifies the viral genetic material that's present in whether it's a nasal swab or in saliva. That material is detectable when a person is actively infected. And so that's one type of test, a PCR test. And both the tests that you're describing that you've taken with the nasal swab, as well as what we're doing here at Georgia State, the saliva test, both of those are PCR tests. Another test is a rapid test or an antigen test. And that test identifies people who are currently infected with the virus as well. It's a quick test that provides immediate results in a few minutes, but it is not a diagnostic test. It's used to screen people and to identify those that need a more definitive test. Those tests have been prone to more error, and so it's for that reason that if you have a positive there, you seek a PCR test. So what we're doing at Georgia State, the saliva test, is a PCR test. We think it's less invasive. If you've had one of the nasal pharyngeal tests that tickles the back of the brain, if you will, but goes deep into the nasal cavity. It's not the most comfortable feeling. So we wanted to make sure that if we had an option that was available to students that would be comfortable, easy, that we took advantage of that. So, we're fortunate to have that option available presently.
I'm speaking with Rodney Lyn. He's the interim dean of the Georgia State School of Public Health and a member of the university's COVID-19 task force. Dean Lyn, just continuing on the testing, I did want to ask about the saliva test. So this is not a DNA test.
No, it's not. Not at all. Like I said, it is looking for, it's looking for viral material in the sample, and there are special machines that examine the specimen and determine whether or not viral material is present or not.
It seems like privacy concerns involving testing and testing data, not necessarily for the public health officials, but for the general public, that a lot of people are just kind of signing off by pressing accept on an app or, agreeing to something or other on a website. But how do you ensure that these test results are secure and the data protected?
Yeah, it's a great question. I mean, we certainly take protecting privacy seriously. It's a responsibility that the university really pays great attention to. We have a medical director for all the tests that we do on campus is obligated to report those tests to the state health department. So our testing is under her direction. Individuals that take a test on campus are communicated with directly to have their results communicated and shared with them so they know their status. They're followed up with by case investigators that work with our medical director to advise them on quarantining and the appropriate steps they need to take if they have a positive case and isolating where that's appropriate. You'll see on our website that all we report there is the number of cases and the results. We're very serious about protecting people's privacy and go to great lengths to do that.
Dr. Lyn, what do you predict for spring 2021? The reason I'm asking about spring is that the vaccine, by all intents and purposes, could be coming out soon, and there's a order of people that would be getting the vaccine first. It seems like, students, and I'm talking about undergrads and even some graduate students, would not be given the vaccine until later in spring. How will the campus be dealing with the COVID come next semester?
I think based on what we know today, things will look this spring a lot like they've looked this fall. As you probably know, scheduling of classes happens weeks in advance of the actual semester beginning. So plans are, being finalized now for the spring semester. And in many ways, I expect things to look a lot like they do now. President Becker has indicated that we will continue to provide testing. Expect the protocols for testing to be similar to what we have now. Expect classroom density to be maintained at 25%. Expect masks to continue to be required in classrooms on campus. So I think in many ways you're correct that the vaccine, once it's approved, is unlikely to be available to college students until late in spring. And as a result, I don't expect the vaccine to have a significant impact on operations at the university in spring. But certainly, we should be, looking forward with optimism. There have been some really positive reports. We're starting to see, the vaccine being approved in other countries and expected to follow, to be approved quickly here in the U.S. as well. So I think we can look to spring with optimism that we will start to protect the most critical and vulnerable individuals and begin a process of working through the population to provide vaccination against what's been a terrible and deadly virus.
In regards to the vaccine, as a public health expert, can someone mandate that you take a vaccine? Because you've got the whole anti-vaxxer movement that's been around for a long time. Can state government or federal government, can you mandate that somebody take a vaccine as a prerequisite to coming on a campus or even going to work back in the office?
We probably want some of our legal experts to weigh in on this question. What I can tell you is that we do have laws in this country that mandate vaccination in certain instances. For example, for your child to go to school, there are certain vaccinations that are required. There are some carve-outs that exist. So, in that context, we do have required immunization. As it relates to COVID-19, I think it's unlikely that we would see a universal mandate. However, we may see a system where individuals have to display via some, immunization passport or that they may have on their phone or some evidence they've been vaccinated before they're allowed to go into another country or to get on an airplane. So that remains to be seen exactly what that will look like. But I expect there to be some powerful disincentives for individuals to say they're not going to be vaccinated. But ultimately, I think each individual will continue to have a choice about whether or not to take the vaccine and when.
And of course, that also involves a whole other set of data privacy and issues involving test results and vaccine, and a national immunization card was spoken about a while ago. Yeah, that's going to open up a whole new can of worms.
Yeah.
Dean Lyn, this week the National Institutes of Health, NIH, awarded GSU a 2-year, $1.3 million grant to study or better understand barriers and motivations for participating in COVID-19 research among Black communities in Atlanta. What can you tell me about this? Seems like a big deal.
It is a big deal, and we're really excited about it. Dr. Heather Bradley, together with her colleagues, Rich Rothenberg, Dennis Rady, Veronica Newton, and one of our community partners, Dazon Dixon, are really working together on this. And we have one of our doctoral students, Herschel Smith, who's been very involved. This is really responding to an NIH initiative, which is committed resources to really working with and looking at underserved populations as it relates to COVID-19. And so we're delighted to be working with NIH on this to better understand barriers and motivators for Black communities for participating in COVID-19 research. This team is going to examine what kinds of things preclude people from participating in these studies. And, we're excited to look at this.
And the African American community was hit very hard by the COVID, especially in the early months of the pandemic, April, May, June, July, and still are suffering from that. This seems like important information. Why does this community or this sector, as you call the underserved, not participate in research? Is it a cultural thing? Is it a stigma thing? Where do you think that lies?
Well, let me first start by going back to what you just indicated, and that's the disparities. When we look at cases, the Black community, for example, sees case rates for COVID-19 2 to 3 times that of the white population. For hospitalizations, it's 4 to 5 times the rate, and for deaths, it's 1.5 to 2 times the rate of the white community. So, this is a significant problem, and it warrants attention, investment, and a recognition that there are underlying inequities that drive these disparities. And I think this study is going to work to really understand what are some of the drivers around participation in research. You asked me what's the driver of some of the low rates of participation in research, and that's one of the things that this study is going to look at. But I think the issue of trustworthiness is one that we've got to think about as a society. And the question is, have we done enough to earn the trust of the Black community in this instance, that they would feel confident and safe to participate in research? There's certainly been cases in the past, the Tuskegee experiments, for example, that have been a real source of broken trust and a real damaging force in terms of the belief that African Americans have in the healthcare system and in the request to participate in research. So there's no question there's a lot of work to do. I'd like to suggest that we need to do more to earn the trust of the minorities that we're seeking to have greater participation from in these studies.
Well, good luck with that. Dean Rodney Lyn, thanks for joining me.
Thanks so much for having me.